this lecture, we're going to be discussing health policy, and specifically health insurance, how it's funded, and how our health systems sort of work in a very broad sense. In order to do this, we need to understand some basic terms. I'm going to start off by talking about universal health insurance. Universal health care, universal health insurance are terms that get sort of tossed about when we discuss healthcare, but are rarely defined because there is no one way to achieve universal health care. So, the two most common models that we can look at are the UK system, where they have the National Health Service, in which all of the medical professionals, doctors, nurses, nursing assistants, staff, etc., are employees of the government. They receive a salary, and it's not dependent on health insurance. So, you're sick, you make an appointment with a doctor in the National Health Service, you see your physician, and you leave. There's no bill. That's not to say that there is not private insurance in England, in the United Kingdom. There is, that you can then use to see doctors outside of the National Health Service. But everybody who lives in England and is a citizen has a right to see a doctor at the National Health Service. That's one way of doing universal health care. Another way is the Canadian model, the third payer model, which means you have the population, you as an individual, you want to see a doctor, you make an appointment with the doctor of your choice, who contracts with the insurance company, which is run by the Canadian government. So in this case, it's the third party, the insurance company is the Canadian government. It's not terribly dissimilar to our Medicaid and Medicare, where the government provides the health insurance, in this case Medicaid or Medicare, and they pay the physicians who contract with those insurance companies. So those are two different ways that universal health care can play out. In both of those systems, you can purchase supplementary health insurance to cover anything that the government either doesn't cover or any additional services that you'd like to receive. In the United States, we have government-run health care. We have Medicaid, Medicare, and we also have health care through our Veterans Services, the VA, and the Indian Health Services. And we can talk about each of those in more detail later. For now, the really important thing that you need to know about Medicare and Medicaid is that Medicare covers individuals who are 65 and older and those who are permanently disabled. So once you hit 65 in this country, you get guaranteed health care. And we'll talk about the challenges of Medicaid and Medicare in another lecture. Medicaid is for individuals who are low income and or permanently disabled as well. Some other terms that you should know have to do with how we pay for our health insurance. So I'm going to jump over here to premium. Premium is, what does your health insurance plan cost? So if you think about it in terms of car insurance, if you want to purchase car insurance, you say the things you want. In that case, it's a private market, and they send you a bill and they say, okay, for the year, this is how much your car insurance will cost. It works the same for health insurance, whether you're buying it as an individual or whether your employer is purchasing it on your behalf. Premiums are not set. There's a significant range, and it really depends on the type and level of coverage you get. The more you want covered, the more expensive your premium is going to be. In addition, there are deductibles. Again, similar to car insurance, this is the amount of money you have to pay out of pocket before your insurance will pay anything at all. Some insurance plans have very high deductibles, some have low deductibles, and some have no deductibles whatsoever. These can also depend on whether or not you're using what's called an in-network provider or an out-of-network provider. So health insurance companies contract with physicians that say, we will agree to provide services and we will accept your insurance. Now, if you want to see a provider that is not quote unquote in your network, for some health insurance plans, that means you cannot see them at all. There is no coverage. You have to pay that bill 100% out of pocket. For others, there is a deductible if you want to see out of network. So you might have to pay $1,000, the first $1,000 before your insurance will kick in. And others, it means there may not be a deductible, but there may be higher cost sharing. And so two ways that you can get at cost sharing are either a copayment or a coinsurance. A copayment is a flat rate that you have to pay every time you see your physician. Again, not all plans have a copayment, but ones that do, it means that you can pay. If I need to see my physician, I walk in the door, they say, "Thank you, you have a $15 copay." So I know that every time I need to see my primary care physician, it's going to be $15. Coinsurance is different in that you're not paying a flat rate, you're paying a percentage of the bill. So if you see your physician and the bill is $100, you might need to pay 20% of that bill or $20. However, if you go and the bill is now $200 and you have a 20% coinsurance, your part of the bill will be $40. And if you need services that cost, say, $1,000, your copay is going to be, or your coinsurance will be $200. So it can get incredibly expensive and prohibitively so. Again, I mentioned that in-network, out-of-network. For some plans, you can see a doctor. If you see in-network, it's a copayment. If you go out-of-network, it's coinsurance. And there again, there may or may not be a deductible. And the type of plan that you get is really going to be determined by a number of things. One being, is it employer-sponsored? So employer-sponsored coverage tends, in general, to be somewhat better and less expensive than insurance on the private market. This has to do with the fact that employers, especially if they are a larger company, can negotiate better premiums, better insurance rates than you could as an individual seeking out health insurance on the private market typically. And so what we end up with are not just individuals who are uninsured, who do not have insurance, but individuals who are underinsured, meaning they have insurance, but the cost of using that insurance is prohibitively high. Either the deductibles are such that they can't afford it, the coinsurance is high, the cost sharing is too high, and in some cases, because this tends to be more for low and middle wage individuals that tend to be underinsured, it may be because taking time off work to see a doctor means that they're losing pay because they do not have sick time or they're hourly wage workers. And so going to a doctor means that they lose perhaps half a day of pay on top of high deductibles and high cost sharing. What did I miss here? So I'll talk a bit more about preventive care and the levels of care providers in the next few slides. So I'm not going to go over that here. But we talked about this employer-sponsored coverage. So what happens when you lose your job? So typically when you have employee-sponsored coverage, they pay a proportion or some portion of your premium. Now, some companies, if they have a very generous benefits package, pay 100% of the premium. More and more, that's not the case. More often, the employer pays a portion of it, and you as an employee pay a portion of it. But it makes it much more affordable. So what happens when you lose that job? You lose your insurance. And so something was developed which was called COBRA, which is continuation of benefits. Pardon me. And that said that you could maintain your health insurance for a period of time after you left a job, after you lost your job. However, the employer is not so, or your former employer now is not so generous as to continue paying the full premium, which means the full cost of that premium now needs to be paid by you out of pocket. So you can maintain your health insurance for a few months after you lose your job, but only if you can afford to pay the premium. And if you've lost your job, that can become incredibly difficult to do. So, levels of prevention. So I mentioned prevention on the previous slide, and I didn't get into too much detail. But really, public health, if there's one thing that you take away from it, is focused on prevention. It's this idea of creating environments where people can be healthy. And so we tend to look at it as levels of prevention. And I will be asking about this on the very first exam and possibly in subsequent exams as well, because I really think this is probably the most important concept you can walk away from this class with. And we define our levels of prevention by the prevention strategy, the disease status, and the effects we hope to see. And so the really big thrust of the work that we do in public health is around what we call primary prevention. And primary prevention seeks to take people who are not sick, but who could become sick, so those who are susceptible, and prevent them from getting sick in the first place. So this can be by promoting access to healthy fruits and vegetables, by reducing air pollution and water pollution, by maintaining safe standards for foods that we purchase in stores, by things like providing vaccines. So we want to take people who are not yet sick, who do not yet have an adverse condition, and prevent them from getting it at all. This is the most cost-effective way of providing healthcare. The next level of prevention is secondary prevention. And in this type of prevention, we're taking individuals who have an illness, who have a condition, but who are currently not yet showing symptoms. And the idea is we want to find the disease before they start showing symptoms and attempt to treat it and hopefully eliminate it. So an example of this are most of our screening practices. So thinking about colonoscopies for colon cancer. And the goal is to find somebody before they're showing symptoms, meaning before that cancer's had an opportunity to grow and spread and cause problems. Identify it and then treat it and remove it. So for colon cancer, it typically starts as a polyp. Individuals, as we age, eventually most of us will develop polyps. And so the idea of colonoscopy is that we can look into your colon. If there is a polyp, it can be removed before it has a chance to become cancerous. Or lesions that are at the very earliest stages of cancer can be removed before they can cause significant problems. And so any type of screening is seen as a type of secondary prevention. So colonoscopy, mammogram, blood pressure, various types of blood work for screening for diabetes, stroke. There's a number of stroke screenings that can be used. So the idea is you might have the beginnings of problems, but they've not yet caused symptoms, and we want to stop it before we start seeing those symptoms. And the final level of prevention is tertiary. And so this is when you're symptomatic. And now we're seeking to reduce complications or disability. So you've broken your leg, you've come out of the cast, and now you need, for example, physical therapy so that you can regain your full range of motion, you can run, and you're not going to have long-term complications. Tertiary prevention, I tend to use cancer examples because I'm a cancer epidemiologist, but another sort of way we tend to think of it as a treatment. But if you have been diagnosed with cancer, we think that it is localized within the organ, but we want to make sure that it hasn't spread. So you might have chemotherapy to make sure that it hasn't spread, that there isn't some rogue cancer cell that's malignant and spreading to another part of your body. So in that case, chemotherapy could be seen as tertiary prevention. So again, this slide you should look at, you should study it. I will be asking a question on the exam and I will give it to you. I will ask you, what are the 3 levels of prevention? So primary, secondary, tertiary. What is the disease status? What's the effect? So be able to define all of those and give an example. People tend to hear public health and only hear the word health. But there really is a difference between clinical health and public health. And so while clinical health seeks to maximize individual positive outcomes, public health seeks to minimize collective adverse outcomes. So rather than trying to make one person as healthy as they can be, the goal of public health is to create systems and environments through multiple avenues, whether it's health policy, environmental health, etc., to try to ensure that everyone has good access to health. So I spoke briefly about um, water pollution. So the monitoring and maintaining of clean water systems is a public health intervention that seeks to minimize adverse collective outcomes. There's also this sort of pyramid of healthcare services. And so at the base, supporting all the levels above it are population-based public health services. Right? So this is the type of public health or the type of healthcare service that affects everyone whether or not they realize it's happening. This is the proverbial safety net. However, if you do get sick, you'll need to seek out primary health care. So this is when you have a cold, you feel like you're coming down with the flu, and you seek out a doctor's services. However, if there's something more than that, let's say you've gone through your screenings, you've presented to your general physician with your heart rate feels like it's been extra high, or they find out that your cholesterol is a little bit elevated, they might refer you out of concern for your heart health to a cardiologist. So this is secondary health care. This is where we start seeing specialists. If, however, you're now presenting with a heart attack and you require more significant surgical interventions, you might need to see a cardiothoracic surgeon. So we have our public health services, primary health care, your primary doctors, specialists, and your super specialists. And this exists in multiple different areas of medicine. Right? So you have cardiologists, you have oncologists, you have surgical oncologists, you have highly specialized for one part of your body individuals who, neurologists and neurosurgeons. Um, and what happens is as we move up the healthcare services pyramid, these more and more specialized services, the cost increases dramatically. And so in public health, we seek to focus on this level, creating environments and creating systems to reduce illness in the first place so that we can reduce cost. Because cost is a significant issue. Between 1960 and current 2018, the cost of our national healthcare expenditures have exploded. And this is why over the past 10 years, there's been this increasing focus. And you can see between 2000 and 2010, we just about doubled our national healthcare expenditures. And so something needs to be done, or something needed to be done to try to bring this into control. Now, what that answer is can be and has been and continues to be hotly debated. But there's no denying that there is a problem. This is not sustainable. At some point, we will run out of money. And so we either need to shift how we're spending the money, where we're spending the money, or how we structure our healthcare system. And so thinking just for the latest data from 2015, healthcare expenditures in 1 year rose 6% to $3.2 trillion. Not million, not billion, $1 trillion. And we're paying, as of 2015, almost $10,000 per person per year for healthcare expenditures. Our gross domestic product, that's how much of our money that we are spending, what percentage goes to healthcare, has been growing. We are at 16.2%. And about half of our national healthcare expenditures are government. And so when we refer back to this idea of universal healthcare and government paying for insurance, almost half of our healthcare expenditures are currently being paid for by the government. And that's up 43%, up from 43% in 1999 and 38% or almost 38% in 1970. So there's already been this shift. And so if you look at the $9,990 overall, about 3,000 of that came from federal sources, almost 1,700 came from state and local. So about half again of the overall, the rest was individual. When you compare that to the UK, right, so I said they have their public, their National Health Service, as well as private expenditures, because that does happen on the private market, they spend about $4,000. So their public and private combined is similar to what our government-only expenditures are. So we spent $3.2 trillion. Where did it go? So most of this is being spent on hospital care, physician and clinical services, and prescription drugs. So if we think about, again, that healthcare pyramid, we're not spending it primarily at the base, at public health level. We're spending it at primary, secondary, and tertiary between these two. There's been some investments. Government administration of healthcare is about 8%. Nursing care facilities, which that's expected to increase. We spend very little on dental and other professional services, which includes sort of eye care, etc. And then of this chunk of other, we look at home health care, medical products, residential health care, and again, of this overall 3.2 trillion, 14% went to other. Of that, 3% is spent on public health activities. So the tiniest fraction, even though we know that public health activities have the biggest bang for their buck and that prevention can reduce the need for many of these other services. And where did it come from? Well, 74% of that cost came from health insurance. And when we look at that, about a third of that is on the private health market, and that includes individual and employer-sponsored. 11% was Medicaid, 20% is Medicare. You have the VA, the Department of Defense, so veterans, active enlisted, CHIP is child health insurance programs, and then state and local Medicaid. So again, the bulk of this is health insurance, which is why when we talk about healthcare costs, this is where it's coming from. Again, just another example of how our gross domestic product, our national spending on health-related purposes has increased quite dramatically. And then this again is looking at what were the projections of what we would be spending based on the Affordable Care Act. And so when we were looking at what they were going to be, these are the final pre-ACA. So if the Affordable Care Act had not been enacted, this is what we would project. Our spending would be sort of increasing quite dramatically. This is what it actually happened upon discussion of the Affordable Care Act, when it was enacted, and then what our most recent projections are. So what's been going on. So we're spending all of this money, and usually you know something's a fairly good investment if you get what's called a good bang for your buck. And so one of the ways that we can think about what we're getting for our money is, are we living longer? And the reality is, in the United States, we spend a lot more on health insurance, but we're not living longer than other countries. So looking at our closest neighbor, Canada, we have a lower life expectancy of about 2.5 years for both males and females, but we pay significantly more than they pay. This is a really busy graph again, but if you look, the gray line, I'm sorry, This is how much we're spending. So for each country, what they're spending. It's on this chart, the axis over here. And the red bars is their life expectancy. That's the United States. We spend by far at least double more than anyone else. And our life expectancy doesn't match up. We're not getting a great bang for our buck. Just to show a different way, this is the curve, so per capita healthcare spending, and this is life expectancy. What you want to see is you want to sort of fall somewhere over here, right before this curve. This is called a return on investment curve. What you want to do is be able to spend relatively little, but still get good life expectancy. So that's the United States. This is Cuba. Cuba spends very, very little, but has very good life expectancy. The United States spends a whole lot and gets about the same for life expectancy. Now, obviously, what you don't want to do is spend little and get little, which happens. But if you look somewhere here around Japan, they spend significantly less, but they get more. And so there is a value in looking at what other systems are doing and why they're working. Now, there's all sorts of reasons why this can or cannot work in the United States, and those, again, are all up for debate and discussion. However, what we know is what we're doing right now is not getting us the outcomes that we would expect for any other investment. Again, this is looking at private health insurance and how we spend it. So private health insurance is unlike other goods and services purchased in the private market. It isn't always available to everybody, and you have to be eligible for it. Eligibility for job-based health insurance is up to employers. Employer-sponsored insurance is voluntary. Not all employers offer it. Those that do don't necessarily offer it to all of their workers and or their dependents. So they might offer it to you, but not to your spouse or to your children. For the most part, uninsured Americans are members of working families, but most aren't eligible for job-based insurance because, for example, they work for a small business that doesn't offer coverage, they only work part-time, or they're dependents of a worker whose employer provides health benefits but not for dependents. And so while there are many reasons for working Americans might not be eligible, for employer-sponsored benefits, they can't be ineligible because they're sick. And so there's a lot that happens here, but what happens is we start seeing this increasing in spending. And so this is inflation-adjusted spending, and we've seen that it has gone up dramatically. So out-of-pocket spending has gone up. So I've talked a little bit about how insurance works. So present, our health insurance system is technically mandatory through the Affordable Care Act. You're required to have insurance, though through employment, the government, or private market. And the key question you must consider when thinking about insurance, what insurance is today, is how it might need to change. What is the level of coverage people should have? What should be included, and who should shoulder the costs? Some dynamics of health coverage or health insurance coverage is that health insurance is not static. And that means that it can change. So in 2004, for example, there were 45 million people who were uninsured. But if you look at a 2-year period, that number goes up to 80 million who are uninsured at some point over to the 2-year period. And approximately 2 million Americans were losing health insurance every month. Often it was just for a short period of time. It might be when they were changing jobs, for example, and they would go without insurance during that probationary period of the first 90 days. And so people would come on and off insurance. So there are people who are long time uninsured, but very often we will experience these short bursts of being uninsured. As of 2014, that number decreased to 33 million. So we're down to about 10% of the population. and almost 90% had insurance for either all or part of the year. And that number went down again in 2015. And the number of people who had insurance for either all or part of the year went up. And so we've seen a dramatic increase in the number of people who have access to health insurance and therefore access to quality health care. As I noted, insurance changes, and how we get it can change. And so coverage options can change with the loss or change of a job, especially because the majority of us are insured either through our own employer, or as the benefit of somebody else who is employed in our family. A change of family status. Very often we have a very high divorce rate, and historically, women have been most at risk for losing health insurance and healthcare access due to divorce. Because if they either are choosing not to work as part of their family decision and therefore do not have their own health insurance when they get through an employer, when they get divorced, they lose that health insurance. Or by choosing to take jobs that allow for more flexibility and forego benefits and then get divorced and they lose that. Having a birthday can cause you to lose your health insurance. This used to be 18 unless you were actively enrolled in college and you had to show proof of insurance to stay on your parents' plan. With the Affordable Care Act, we extended that out to the age of 26. Or if you move. So health insurance is not portable across state lines. Health insurance companies work within particular states, and there are a number of differences. And so if you move out of New Jersey and into Kansas and they don't offer your health care plan, you might be uninsured for a time. We are currently at our lowest level of uninsured ever, which is a really good thing. And prior to the creation of Medicaid, it was up near 25%. Again, everything was pretty much through the private insurance market or your employer. So we saw a dramatic decrease in uninsured due to the creation of Medicaid and Medicare. It started to creep back up, and we started to see higher and higher rates of uninsured. And you can see here that with the first open enrollment for the Affordable Care Act, those rates have, again, had another dramatic decline. Historically, this has been true. The young adults aged 19 to 25 have had the highest rate, or the most likely to be uninsured, which is why the Affordable Care Act did the dependent coverage expansion to age 26. And so we had that. They expanded the age up to 26, and you saw, again, this significant decline. And then again, with the open enrollment, it declined again because individuals were able to purchase affordable health care on the exchanges and in the open market. Individuals aged 26 to 64, we measure it that way because remember at 65 you're eligible for Medicare, has consistently hovered between 15 and 18%. There was a slight increase between 2007 to 2013. A big chunk of that corresponds with the recession, so a number of people lost their jobs and were no longer eligible for employer-based health insurance. Again, with the mandate, that decreased. In 1997, the Child Health Insurance Program began. This was a health insurance program specifically for individuals under the age of 19. And again, it was based on eligibility of your parents, based on income, and it was a sliding scale, meaning the more you could afford to pay, the more you paid. And that has dramatically reduced uninsured for children. The more poor you are, so if you're this is less than 138, that means you are at the poverty, right around the poverty line, maybe slightly above or lower. So the poorer you are, the less likely you are to have insurance, the more likely you are to be uninsured. With the change in the Affordable Care Act, we've actually seen reductions in uninsured across from the individuals who have the highest incomes to individuals with the lowest incomes. We haven't done away with uninsured entirely, but we've made significant progress into reducing those numbers. Again, this is looking at the decline. So as these numbers get higher, that's actually a better thing. In states that did do the Medicaid expansion, so we'll talk more about Medicaid in another lecture, but the idea is to qualify for Medicaid, you have to be very, very poor and have children. And so in most states, if you were a single individual who was poor, who did not have young children, you were not eligible. Medicaid expansion was going to provide additional funding from the federal government to the states to allow Medicaid to cover more individuals. This was fought to the Supreme Court, with some states saying they did not want to have to offer Medicaid expansion. And what you find is that in states that did offer Medicaid expansion, their decline in uninsured rates went down faster and more than in states that did not expand. Massachusetts is probably the exception because Massachusetts already offered a form of universal health care at the state level. So the numbers didn't have to come down as much. So we keep talking about health insurance and how it's declined and, why it's important, but really, what is health insurance? So why do we have it? What's the value? So it's a product. And the idea is you're paying into it and you hope you never need it. So much like car insurance, you can pay for car insurance your entire life and never have an accident. But you hope that when you have an accident, it's there to cover you. In the past, there have been a lifetime maximum, meaning you can max out the amount of health insurance you could use. It's again a prepaid health benefit. You pay into it when you're healthy so that it's there when you are not. It's a promise of insurability in the future. Again, you might pay for it for a lifetime and not need it until that one moment when suddenly you do. It's negotiated rates and often negotiated access. So you're really purchasing this idea of care management. So you are paying for a service and they are telling you what that can provide. So that will mean, can you get your vaccines? There's a new treatment. Will they pay for it? Right? So this is a type of care management. And this is also what's called an indemnity. So indemnity type plans mean that the idea is that everybody pays into it, but we don't all take out of it at the same exact time. So for example, I may pay into insurance, my health insurance. I've been at Montclair, for example, for over 10 years. I may have gone for my regular checkup, but never had anything catastrophic happen. In the meantime, somebody else did. Somebody else in that 10 years that I was paying into my health insurance and that I wasn't typically using, but somebody else who's in the same health plan because we're at the same employer had a heart attack. And so that might cost tens of thousands of dollars. But at the same time, other people are paying in so that the year that I gave birth and I needed a C-section, which was $65,000, I didn't pay that $65,000 out of pocket. But that's not going to happen every year. And so really the value of insurance is the more healthy people you have all paying in at the same time, the lower the cost is for everyone, and it's there for when you need it. It's cost sharing. So types of health insurance. Private health insurance, so non-government health insurance, accounts for about 67% of insurance as of 2015. The vast majority of health insurance is employer-based, and about 15 to 16% is purchased on the public market. So I call up Aetna and say, I would like to purchase a plan. That doesn't happen very often, in large part because it's prohibitively expensive. Public health insurance, meaning insurance provided by the government, accounts for about 37% of all health insurance. And this is Medicaid, Medicare, and military. And that's both current enlisted and veterans administration costs. So why does it matter? Well, if you look at being insured versus uninsured and individuals reporting barriers to healthcare, almost half of people who are uninsured said that they postponed seeking care because of cost. That means they didn't go for those primary prevention. They might not have even gone for the secondary prevention. They might not be going to their regular doctor because it's too expensive. And so they may be postponing care until they can no longer postpone it, which means they're entering the healthcare system at higher levels on the health system pyramid. Over a third, said they needed care but at some point but didn't get it. Didn't fill a prescription because they couldn't afford it. Had problems paying for medical bills. And almost a quarter have been contacted by collections agencies about bills. Now that's our uninsured. But 16% of individuals who have insurance also had problems paying their medical bills. 13% said, I had a prescription, but I couldn't fill it anyway, even when you're insured. Because remember, I said cost sharing varies by health insurance plan. And these are often the individuals who we consider to be underinsured. They have insurance, but they still can't afford to use it. Why else does it matter? Well, because individuals who don't have health insurance were twice as likely to be diagnosed with late stage colorectal cancer, lung cancer, skin cancer, and almost 3 times as likely to be diagnosed with late stage breast cancer. For colorectal, melanoma, and breast cancer, these are incredibly important numbers because being diagnosed at an early stage dramatically increases the probability of survival. And so if you're uninsured, you're more likely to be diagnosed at a later stage and you have less chance of surviving. Not having insurance can kill you. So again, this is just looking at 2016, where most people under the age of 65 getting their health coverage. Almost 160 million are getting it from their employer. Just under 80 million are getting it from Medicaid or CHIP. Medicare accounts for a very small proportion, and so does private non-group coverage. And then there are still about 37 million people who are uninsured. This is looking at 2006 and how healthcare coverage has changed. So again, we're looking at the uninsured rate is the darkest bar. And so we had uninsured rates ranging from 14% up to 43%. And Medicaid or other public insurance, so Medicaid, Medicare, Veterans, Department of Defense, range somewhere between 9% and almost 20%. This was in 2006 with the enaction of the Affordable Care Act. We've seen some changes. And so what we've seen is that the rate of uninsureds have gone down across the board. And there's also been some interesting shifts. So while for white and Asian Americans, the rate of uninsured hasn't changed all that much. So it was 14 and 18%. We've gone to 13 and 18%. The number of individuals getting their insurance in the public market through the government sources has actually increased. So it went from 9% for both up to 15% for both. For Hispanic, the uninsured rate declined dramatically, more than 10%. And that's been accounted for again by the Medicaid expansion and the purchasing of private healthcare through the healthcare exchanges and the SHOP programs. And you can see the same thing for African American and American Indians. So there's been a decrease and there's been a shift. And this again is just looking really at those extremes. So for poor families who are working, an individual in the home is working, the vast majority of them are not offered health insurance through either their own or their spouse. About 15% declined their offer from either their own or their spouses, usually because they had one or the other and they didn't want to have both because of the cost sharing. And only 30% were covered by their employer. Versus high income workers where 92% were covered either by their own or their spouse. And only 4% were not offered health insurance. And so when we tend to think of these situations, people say, well, you just need to get a job, right? If you don't have insurance, get a job. I don't see what the problem is. But the problem is, if you are on the lower end of the earning scale, you can have a job and still not get insurance because they might not offer it. A more complex look at this is looking at, again, low income, low middle high, and high income. And what we have seen is that the percent of workers offered employer-sponsored insurance has gone down in each of those categories. So employers are less and less likely to offer insurance. You're still much more likely to get it if you're a high-income worker than a low-income worker, but it's gone down across the board. And again, it's an older slide, so I'm going to skip past that. Another way of looking at it, about 56% of all households have employer-sponsored insurance, but there's a dramatic difference whether you're low income, so where it's only 12%, versus high income, which is 83%. If you look also at the family premiums or single premiums, those have gone up between 162 to 200%, while the federal poverty line has only gone up about 41%, meaning cost of insurance has gone up, has skyrocketed. It's been a dramatic increase, but your eligibility for government insurance has not. So who's eligible for private health insurance before the Affordable Care Act? Employer-sponsored insurance, right? So that's up to the employers. Who gets it, what they offer, really is depend. You are less likely to be offered health insurance, if you worked at a small versus a large firm, if you were part-time or seasonal versus full-time, low-wage workers, newly hired, dependents rather than the employees themselves, and most retirees do not retire with health insurance. That was done, and it's almost exclusively been done away with. The big difference between employer-sponsored insurance, ESI, and individual insurance is that employer-sponsored insurance cannot be based on your health status. So if you work there, you cannot be denied due to a pre-existing condition. However, individual insurance, which is purchased by individuals either within or outside of the marketplace, age and health status were a determining factor, and that was called medical underwriting. And that meant that individuals could be covered differentially based on their health status, their current health status. So what did health insurance cover prior to the Affordable Care Act? Standard policies were rarely defined by law. It really was up to the insurance company what they wanted to offer, and if it was employer-based, what they wanted to pay for. There were no mandated benefits, and there were benefit limits. So there was a maximum out-of-pocket for annual, lifetime, and different services and cost limits. So the insurance company can say, sorry, you already maxed out your lifetime health insurance. We will pay no more. Now, typically that was $1 million, and that sounds like a really big amount of money. But think about a child who had cancer, which is incredibly expensive to treat. And you're saying that they have now used up all of their health insurance for their entire life, and they might only be 6 or 7 years old. We already talked about the deductibles, copays, cost insurance. Sometimes there were out-of-pocket cost-sharing maximums. That wasn't always the case. It really depends on the plan. The terms of coverage were defined by provider networks and care authorization and utilization reviews. So one of the ways that health insurance companies keep costs down for themselves is that you have to get prior authorization before you get certain services provided. utilization review. So let's say I feel like I need physical therapy, my doctor feels I need physical therapy, the insurance company needs to agree that I need physical therapy based on my medical records before they will agree to pay for it. That's still the case. There could be condition exclusions based on pre-existing and other conditions. Employer-based insurance generally covers more with less cost sharing. Small businesses have more cost sharing. They have less negotiating power with the health insurance companies and provide less coverage, typically. An individual insurance on the individual market is typically less inclusive and the most expensive with the highest cost sharing. So what are some conditions that could be denied by the individual market insurers? Well, if you currently had cancer, you were being treated for it. If you have HIV/AIDS, diabetes, MS, if you were currently pregnant, they would not cover you. If you've had a stroke, always denied. Often denied, you could be denied if you were overweight. If you had had cancer in the past, again, if you had a childhood cancer and you're cancer-free now as an adult, you could still be denied. If you had a history of high blood pressure or asthma. And there were a number of cases that were actually denied due to severe acne and even things such as hay fever. You could be denied for a lot of reasons that fell under this umbrella category of pre-existing condition. Again, prior to the Affordable Care Act. Prior to the Affordable Care Act, not all large firms provided health insurance to their companies. Almost a quarter of uninsured workers worked for firms that were these large companies, over 1,000 employers. Only 35% of uninsured workers worked at these small mom and pop, right? So they always talk about the small companies that can't afford insurance. Very few uninsured workers worked there. Small firms claim that they can't bargain well with insurance. They can't afford to pay for health insurance. They can't lower the amount that they need to pay enough, because then they wouldn't either be able to pay their employees or be profitable. Large firms can't make that claim, at least not on a rational basis. So what they say is that workers prefer cash to the insurance benefit. Many are part-time workers, which is really a subcase of unwillingness to sacrifice the money wages argument. And minimum or near minimum wage workers cannot have their wages reduced sufficiently to make up for the cost of the health care benefits. And these economic arguments are often tied in with this minimum wage mandate argument, right? So the idea that these large companies say is, if you raise minimum wage to a living wage, we won't be able to offer them health insurance. And so individuals need to decide, would you rather have health insurance for those times when you may need it, even though you may not need it right now, or have a living wage? So do you want to have food on your plate now and risk dying later? Or do you want to have that coverage for later if you might need it and not have enough money for food? That's how the argument often gets shaped. So the Patient Protection and Affordable Care Act, which is also known as the Affordable Care Act, the ACA, and was branded as Obamacare, which was enacted in 2010. So it was signed into law in March 2010. And since then and during then, I don't think many people really knew a whole lot about it. But there's a lot of good that it's done. So the overview of the Affordable Care Act, the goals were to increase affordability and accessibility to healthcare, to look at the role of public programs, again, look at public health, and try to start shifting our focus away from treatment to prevention, to improve the quality and efficiency of healthcare, to prevent chronic disease, again, by improving public health, to train and increase our healthcare workforce, to improve transparency and program integrity, to improve access to innovative and new medical therapies so we're not waiting as long to get to them, to provide for community living assistance and services and supports so that we have fewer people living in nursing homes and are more able to stay in their homes. There were some revenue provisions, so how it's going to be paid for. and really looking at quality, affordable care. So, not just making care more affordable, but making sure that that affordable care is also high quality. In the first year of the Affordable Care Act, insurance companies could no longer drop you when you got sick. All children would get coverage regardless of whether or not they had a pre-existing condition. There were no more lifetime maximums on benefits, and young adults were able to stay on their health insurance until the age of 26. In addition, a number of preventive services were required to be offered for free through health insurance, and this included blood pressure, diabetes, cholesterol screening test, many health cancer screenings, many cancer screenings including mammograms and colonoscopies, health counseling services, routine vaccinations, flu and pneumonia shots, and well baby and well child visits up to the age of 21. All meant if you had insurance, you would go in and you wouldn't need to pay a copay for any of those. As of 2014, U.S. Citizens and legal residents were required to have qualifying health insurance, and there was a phase-in of tax penalties for those without a coverage. The maximum penalty was just under $700 per person per year. Employers with more than 50 employees that did not offer health coverage or health insurance were penalized. They were fined. And they sought to create these state-based American health benefit exchanges and small business option programs, through which individuals and small businesses with up to 100 employees could purchase qualified coverage. So if you recall, I said at the beginning, it was really hard to purchase insurance on the private market because you don't have the bargaining power. And what this allowed was sort of the creation of bargaining groups by bringing together individuals and small businesses who otherwise wouldn't be able to. Again, it sort of solidified this essential healthcare package that provides a comprehensive set of services that generally must be included in policies sold through those insurance exchanges. And it provided subsidies and limited out-of-pocket expenses for individuals who were not eligible for Medicaid. So they made too much money, but were not at the top of the wage earners. So those middle income individuals could provide subsidies so that they could purchase insurance to make that insurance more affordable. And pre-existing condition exclusions were done away with for adults. So they were done away with initially for children and then adults in 2014. In 2015, states were allowed to form multi-state healthcare choice agreements. So I said initially you weren't allowed, there's no portability of insurance across state lines. As of 2015, states were allowed to negotiate that so that you could have healthcare insurance be portable across state lines. They would also began taxing health insurance policies that had the greatest amount, so those Cadillac services would now be could be covered and charged. So my screen is not advancing, I'm sorry. So I'm just going to talk a little bit. That was actually my second to last slide. Finally, where are we now? So almost a year ago exactly, there was an attempt to repeal the Affordable Care Act and replace it with the American Health Care Act. And so that was not successful. They then attempted to repeal it without replacing it. That was also not successful. However, as of December 2017, in the most recent tax bill, they repealed the individual mandate penalty, which meant you no longer had to pay that $700, or it was roughly about $67 per month that you were uninsured. As a result, it's expected that healthcare uninsured rates will go back up and that health premium costs will go up. However, it was expected that by taking away the individual mandate, there would be fewer people who signed up for health insurance through the exchange, and instead there was actually an increase by 5%. So I think individuals are getting used to the idea of health insurance, having the health insurance. Individuals who may previously have been uninsured are seeing the benefit of not being uninsured, of having health insurance. And what's still in place is the expanded coverage through Medicaid in the states that sought that out, the protections for individuals with pre-existing condition, and importantly, the premium subsidies for lower income individuals. And so there have been some changes, and there continue to be attacks on the Affordable Care Act, and debates about whether it's sufficient, whether it went far enough, whether it went too far. But this really is where we are right now.